So nutritional will be the most common ones. And what are the pointers that if you have somebody who comes to you with the rickets for the first time, has a possibility of a non-nutritional or a refractory rickets?
Having fractures associated with rickets like condition, or someone who has a failure to thrive, then these are the conditions.
So significant failure to thrive, features of RTA like polyuria, acidotic breathing. If you have a pathological fracture, you have to get worried about in that scenario. Now, what are the common causes of non-nutritional rickets / refractory rickets, Vibha?
Rickets. Another would be the RTA.
So renal tubular acidosis, hypophosphatemic rickets. And the most common would be renal failure. So that is something, of course, you will do it in the initial phase. So we'll try to go forward on that. So rickets seems to be a reasonably simple condition to evaluate, but often we have got confusions which go off. So we had this 3-year-old boy who was referred to us in which of quote unquote a diagnosis of refractory rickets, had been given vitamin D 60,000 international units and complained of bone pain and a high alkaline phosphatase. And based upon these findings, the clinical team thought that this could be a possibility of a refractory rickets. But as we will discuss subsequently, that we do have some physiological responses to vitamin D, which include an increase in bone pain and an increase in alkaline phosphatase, which do not indicate a refractory rickets. And what we need to look at is the line of healing which was present in this case. So while this case was unnecessarily being advised, a lot of investigation in the form of a blood gas, calcitriol level and PTH, they were not required. So what we need to understand is that there are certain scenarios in which you will respond in a way and you don't need to work up extensively from that regard. So this is a normal response for rickets. On the contrary, we have this 14-year-old boy who presented to us with lower limb abnormalities predominantly, and had been given huge amounts of vitamin D, and there was no line of healing. He was again referred as quote unquote nutritional rickets. So in the first case, we were making physiology into pathology. Here a pathology was turned out to be in a physiological cause, and this unfortunately resulted in the development of nephrocalcinosis. If you have a late onset rickets with predominant lower limb abnormalities with a normal PTH, normal calcium, think of hypophosphatemic rickets. So when we talk about rickets, we have to balance between the not doing too much workup where it is not required, while not missing on pathological cases. So this missing and messing is something which we want to avoid. Rickets overall is a reasonably common condition, usually nutritional, but refractory rickets may pose challenge, as we saw in the second case in that perspective. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information about pediatric endocrinology, including resources and courses. Our e-learning portal on YouTube, which has got a lot of videos on pediatric endocrinology. Our validated courses, which provide information, including fellowship course and postgraduate courses as well. And our regular programs in the form of grand rounds, journal clubs, and PG lecture series as well. We've got publications across board from protocols to advanced in basic pediatric endocrinology and mobile applications which guide assessment. Questions that we have to answer in terms of the overall part of rickets is it really rickets? That's the first question, of course. Then if it is rickets, is it refractory or not? And finally, what's the cause? So when we talk about rickets, we of course are talking about bony deformities. So we are all aware about the classical deformities like genu valgum, genu varum, and windswept deformity. What you need to understand is that there is a physiological genu varum which happens in infancy. So if you have a genu varum, there are no wrist widening, there is no other changes, don't be too much worried about that. But if you have a windswept deformity, or if you have a clear-cut genu valgum, this is a pathological cause which you have to worry, of course, and then X-ray will give you a good picture. You can look at the hand X-ray, which gives a good picture, or even the knee X-rays. And we talk about the cupping, which is basically the widening and there is a gap there, fraying, which is the irregularity, and splaying, which is the pressure the bone is forming on a weak bone, causing it to splay out from that perspective. Now, the next big question before you want to evaluate is it really refractory? So we have to follow the protocols as far as the treatment are concerned. There are global recommendations which are also there, and IAP has also come up with their own recommendations for vitamin D treatment, which basically In most cases, beyond 1 year, they're talking about 3,000 international units every day. So this is something which we would like to recommend, 3,000 international units daily for 12 weeks. And alternatively, you can use 60,000 units fortnightly every 2 weeks. Now, the big message here is that injectable forms are not recommended because they will cause very rapid rise and rapid fall of vitamin D, and they will have a risk of hypercalcemia. They are specifically reserved only for malabsorption. Always remember that you also give with calcium as well, because if you have calcium deficiency, you will again have issues in that perspective. So give for 12 weeks and then reassess. And then, of course, once you have treated it, you have to give a maintenance level of vitamin D in that regard. And parenteral vitamin D only if there is malabsorption. Once you give vitamin D in the right doses, the chances of toxicity are very, very less. So don't worry about toxicity. But if you give a high dose, if you give a parenteral therapy for a longer duration, there may be a risk. Now, what happens when you treat, when you give vitamin D, your calcium absorption increases, your phosphorus absorption increases, so your calcium levels go up, you will have bone formation, calcium goes up, PTH goes down, so phosphorus automatically improves on that. Now, once you have got this deposition, you may have hypocalcemia if you are not giving calcium. This is what is known as a hungry bone syndrome. And you may also have bone pain because of bone formation. So this is a normal phenomena. Do not worry about this and think that this could be a feature of refractory rickets. Now, because of rickets, the bone turnover was low. Once you have treated, the bone turnover increases. And as Vibha said, that your bone formation markers like ALP levels will go up because they are required as part of the bone formation. So this high ALP does not mean that you have got a refractory rickets. So this is something you need to understand. So when we are thinking of refractory rickets, we need to first of all be sure that you have rickets. Second, you should give enough dose of calcium and vitamin D, and then you do not find a line of healing. This is what is important. The misguiders are high ALP, low calcium, and bone pain, which may happen as a normal response, which you need to be aware of. Remember that other conditions may look like rickets, particularly skeletal dysplasia, and we know many of them are specifically having the epiphyseal involvement. Pseudo-hypoparathyroidism will present with hypocalcemia and hyperphosphatemia. Fluorosis, especially in endemic regions, and you have to examine the teeth. They will look yellowish discoloration, and you will have osteosclerosis, which are the characteristic features, and hypophosphatasia, in which the ALP levels will be very, very low. You do not need to wait in everybody who comes to you with rickets. Okay, I'll wait for a few months for response. If already the child has significant polyuria, fractures, failure to thrive, you have to start thinking that this could be an abnormality. 3-year-old boy with rickets giving a dose of vitamin D 60,000 units, which we discussed earlier. And we said that high ALP and bone pain does not mean refractory rickets. This is a normal response. So don't worry about that and follow up. 4-year-old girl given osteocalcium 5 ml BD without being given any vitamin D. So this clearly is inadequate treatment. And she was labeled as refractory rickets. So this is not really refractory rickets. This is something which we don't need to worry. This is inadequate treatment from that perspective. 7-year-old girl with refractory rickets with a high phosphorus. So you can see that she is short. She has classical lower limb abnormality, but the phosphorus is high. The first thing I'll think about is renal failure, which was normal, which is creatinine was normal. So this turned out to be pseudo-hypoparathyroidism. So PHP may present masquerade as vitamin D as rickets, and then you don't need to worry too much about. On the contrary, if you have long-standing vitamin D deficiency, you may also have secondary PTH resistance. So you have to be very cautious. Get a vitamin D level done in this scenario. If your vitamin D is low, then you have to think of vitamin D deficiency first as a possibility. But yes, hypocalcemia, hyperphosphatemia, normal creatinine with rickets, think PHP as a possibility, as an alternate diagnosis in that regards. Now we know it's refractory. How do we evaluate for cause? If you have clear-cut history of tetany, spasm, cramps, think of a calciopenic rickets. If it's polyuria, think of RTA. If there's a predominant lower limb involvement, think of a phosphopenic form of rickets. If there is anemia with rickets, think of celiac or kidney disease. If there is alopecia, as Vibha said, vitamin-independent rickets would be a likely possibility. Get an eye examination done for corneal crystals, which will indicate cystinosis. If there is hemangioma, this could be a FGF-producing tumor. And fluorosis, as I said, mottling of teeth, yellow discoloration. Think about these possibilities. If there is significant growth failure, renal calcification, hypokalemic paralysis, polyuria, acidotic breathing, think RTA as a strong possibility. If there is a late onset lower limb abnormality, coarse tabaculations, dental abscesses, enthesopathies, spinal stenosis, think of a possibility of hypophosphatemic rickets as we should. So this is what our study was, and what we really look at in this perspective is that biochemical investigation will give you a clue. Of course, phosphorus levels will be low in most cases. Alkaline phosphatase is interesting. They will be lower in distal RTA compared to other forms, because distal RTA is a low bone turnover state. So ALP will give you a clue. Phosphorus levels and calcium levels will also give you a clue. So if your calcium is low, it pretty much excludes the possibility of hypophosphatemic rickets from that perspective. Now, if you look at phosphorus level, remember that as the bones are growing and bone formation happens, you will have a higher level of phosphorus. So use age-appropriate cutoff rather than the adult cutoffs, which are often given in many of these references in this perspective. Now, why often we spend a lot of time in measuring the urinary phosphorus excretion to identify whether there is really phosphaturia or not. There are various ways of doing it. You can look at the fractional excretion of phosphorus, which is basically the urinary phosphorus upon plasma phosphorus into plasma creatinine upon urinary creatinine. Standard way we calculate the fractional part. This can then be converted into a tubular resorption, which is 100 minus this amount, how much phosphorus you are absorbing. And you can also convert it for the phosphorus level and GFR level, which is the TMP GFR. So tubular maximum of phosphorus for GFR is considered to be the best marker as far as the phosphorus excretion status is concerned. A lot of people do a lot of investigations, or the problems are you need timed collections of phosphorus. Some people talk about spot collection, and there is so much variations there. Now, how important is this test really in terms of assessment? Now, you remember this, TMP-GFR, this formula says is phosphorus minus this level. So, whenever your phosphorus level is low, your TMP-GFR will anyway be low. So, rather than doing so much academic exercises, if your phosphorus is low, you have to understand that everybody who is eating should not have a low phosphorus. If somebody is in the ICU on TPN, then I can understand. If somebody has hypomagnesemia, I can understand. But otherwise, in a normal individual, low phosphorus means that you have a renal loss. So don't worry too much about this. Low phosphorus, I'll be very confident that this is because of excretion. And your normal value of 4 to 8, if your actual phosphorus level is 2, why bother about TMP-GFR? It has to be low in that perspective. Urinary calcium excretion can give you a direct clue for RTA. So you have to do a 24-hour or a spot sample if you have got hypercalciuria, more than 4 milligram per kg per day or 0.25 milligram to milligram. You are worried about hypercalciuria, and particularly think of a possibility of RTA, hypophosphatemic rickets with hypercalciuria, or Dent's disease as a possibility in that regards. Now, RTA is an important differential to consider. For RTA, you need to have acidosis, which is basically metabolic of origin, with a normal level of anion gap, normal level of renal functions, and ammonia excretion, which indicates a positive urinary anion gap. So this is the workup you will consider for RTA. Now, if we now classify rickets, and the common conditions I put are VDDR, hypophosphatemic, RTA, renal failure, the most important investigation is phosphorus. Everybody who has got rickets will have a normal level of phosphorus. If your phosphorus is high, you're dealing with renal failure or pseudohypoparathyroidism. If your calcium level is low, it excludes hypophosphatemic rickets. If your PTH is high, it excludes untreated hypophosphatemic rickets. High urinary calcium indicates renal tubular acidosis, and pH will of course give you acidosis in RTA and renal failure. So these are the way you can understand and get the diagnosis from that perspective, which will be identified in that regard. So based upon this, we proposed an algorithm maybe around 18 years ago, and our current algorithm is slightly different but quite similar. So if you have a patient with rickets, assess the response to vitamin D. We talked about 3,000 international units beyond 1 year or 60,000 international units fortnightly for 12 weeks. Assess for response. If there is a response of vitamin D in the form of line of healing, don't worry. End of the story. If your rickets is not responding and your phosphorus level is low, you've got multiple differentials. 3 major differentials: RTA, hypophosphatemic rickets, and VDDR. So you look at blood gas. If there is acidosis, this is RTA. You classify based upon urinary pH. You can do fraction excretion of bicarbonate. You can do a urine to blood CO2 difference to identify distal versus proximal RTA. Mild metabolic acidosis should not raise the possibility of rickets here as RTA. Think of secondary hyperparathyroidism also in that regards. One condition I find often confusing to identify is proximal RTA, which may not have acidosis all the time. Urinary pH may be variable. So look for other signs. Look for urinary glucose. So if the glucose is there, often we miss it. This will be indication that this could be Fanconi syndrome. If the blood gas is normal and your calcium, phosphorate, calcium and PTH are also normal, this is hypophosphatemic rickets. If, however, you have got low calcium or high PTH, this is vitamin D dependent rickets. You classify based upon calcitriol, which is high in VDDR2 and normal in VDDR1. So if you now look at the algorithm, calcitriol is only indicated in refractory rickets with normal phosphorus, normal blood gas, hypocalcemia or hyperparathyroidism. So if you do random, everybody calcitriol, your levels will get confused and you will label everybody as VDDR2. So this is something which has to be avoided. Now, of course, if your phosphorus is high, your diagnosis becomes easy. Your creatinine is high. This is renal failure. Alternatively, you're looking at PHP. So mainly looking at the response to vitamin D, phosphorus, blood gas, and then maybe vitamin D 125, you will get the diagnosis in most cases. So 4-year-old girl, rickets, 2 courses of vitamin D, no improvement, also has abdominal pain and anemia. So parental vitamin D was given and there was a response. So what are you thinking here, Dr. Dhwani, in this case? Yeah. So this was one case in which we gave the parental vitamin D because we were suspecting malabsorption and TTG was strongly positive. So consider celiac as a possibility. 5-year-old girl with rickets and polyuria, you see significant failure to thrive. There is metabolic acidosis with a high urinary pH labeled as distal RTA. Do you agree, Vibha?
So before mentioned this diagnosing starting.
So as we said, you need to have a normal anion gap, you need to have a normal urinary anion gap, and you need to have a normal creatinine. So in this case, we have bypassed the picture. So here the phosphorus was very high and we should have thought of CKD. So it's a renal acidosis, but it's a renal glomerular acidosis rather than a renal tubular acidosis, so to speak. 4-year-old boy with rickets, calcium is 8.2, potassium is 3.8, phosphorus, ALP is definitely on the higher side. There is a metabolic acidosis minus 6.5. What do you think? So first presentation doesn't have any history of giving vitamin D. So this is a mild acidosis. And as I said, if it's distal RTA, very unlikely. Proximal, yes, but you don't have any other manifestations. Proximal RTA presents much earlier in age. So what we are seeing here is that this is not fitting into RTA. It is actually vitamin D deficiency causing secondary hyperparathyroidism. So you have to be wary about false diagnosis of RTA as well. 2-year-old girl with failure to thrive in rickets, and you can see clear-cut features of rickets. There is significant bone abnormality, including loser zone. She is failing to thrive as well. Phosphorus is 1.9, ALP is 1200. Is it? hypophosphatemic rickets?
Calcium is low and then phosphate is
Calcium is normal.
giving as hypophosphatemia.
Okay, this was labeled as hypophosphatemic rickets. Now, what I need to understand is that if you have to do a blood gas first in this regard, and there was mildish metabolic acidosis, very early onset, mild metabolic acidosis, very low phosphorus, very high ALP. This is proximal RTA. And your job is not done once you diagnose proximal RTA. You have to look at the eye examination, genetic testing, so tyrosinemia, cystinosis, and all those can become in that perspective. 12-year-old girl with multiple fractures, as you can see here, and very, very weak bone, failure to thrive, polyuria, and myopathy. There is metabolic acidosis, as you can see. Creatinine is normal, and anion gap is normal. So this is RTA. Now, what do you think? This is distal or proximal RTA? So this is more severe, more fractures, more likely distal RTA. Urinary anion gap was positive. Again, confirming RTA. What you are seeing here is urinary pH is 5.8. This is alkaline. Again, RTA, but there is amino acid urea. So Fanconi syndrome. So secondary hyperparathyroidism can cause that. So late onset, severe disorder, fractures, alkaline urine, think of distal RTA. Don't get too bothered about this amino acid urea. This is part of the Fanconi syndrome picture, which is there in that perspective. So this is important. 3-month-old boy with seizures, rickets, and what we are seeing, phosphorus is very, very low. PTH calcium is also low. Vitamin D is 40, calcitriol is 200. So what are you dealing with?
There is a very severe hypocalcemia presenting early, and this calcium level is very high at the 25 hydroxy is like within the normal limit. Yeah. So this is pointing more towards this VDDR2 where there is a resistance. So this looks like your calcitriol is there, your vitamin D is there, it's not working. So VDDR2 in that regard. 1-year-old girl with refractory rickets, calcium is 6.9, phosphorus is 2.2. So phosphorus is low, calcium is low, ALP is high, PTH is also very high. Now vitamin D is high and calcitriol is 10. Yeah. So this is a classical scenario that you are thinking of VDDR. And again, there's a confusion between VDDR and proximal RTA, which may be a part of the secondary hyperpara. So we give calcitriol and that would result in improvement. So again, VDDR1 will be hypocalcemia. This will be less severe than VDDR2. But yes, you have to consider this in appropriate situation. This case we already discussed. So Vibha, we have this guy, a girl with phosphorus, a child with phosphorus of 1.8. Base excess is -4. Calcium and PTH are both normal. So what are you thinking of? So this is most likely a hypophosphatemic rickets. Now, very important is to look at urinary calcium here as well. If you have hypercalciuria, you're dealing with hypercalciuric variant of hypophosphatemic rickets. Go for a family history, especially ask for maternal uncles, cousins. Even mother may have milder disorder because it's a X-linked dominant disorder. And this family history will give you a diagnosis of X-linked hypophosphatemic rickets in that regards. 6-year-old boy with no response to therapy. Calcium is normal, phosphorus is 2.2, ALP is high, PTH is normal. Calcitriol and vitamin D was advised. Do you agree? So there was no response. It's a refractory rickets. Okay. So blood gas was normal in this case. And now this child was on calcitriol, complaints of abdominal pain, polyuria, dehydration. What are you thinking of? So hypophosphatemic rickets with possibly hypercalciuric variant. So it's very, very important to really look at urinary calcium. look at ultrasound before you start treatment, because otherwise you will have nephrocalcinosis which will develop in this scenario. 16-year-old boy with rickets, very low level of phosphorus. Now ALP is very high, PTH is normal, so we are dealing with hypophosphatemic sort of a physiology. Now family history is not there, no hypercalciuria. So what are you thinking of? So you have to consider some acquired cause because it's a late onset. Why would it be so late? So generally you have to look for imaging. Genetic study was normal. MRI showed a soft tissue tumor, and if you remove that tumor, that will improve. So this is tumor-induced osteomalacia, where the tumor is producing FGF23, and that will improve from that regards. So all this algorithm we have developed our approach pathway, which guides you in terms of assessment, which is available as part of our app, provides the right diagnosis in most cases. I want you to have a look at our website, at our various courses, our publications, our learning portal, as well as the mobile application.